So my background as a brain surgeon working in a country where very few limited resources were allowed and the tremendous amount of neurological patients were in need pushed me towards thinking that the necessity, like it was meant to be developed a new concept and new ideas so that we can solve the problems in neurosurgery where accuracy and precision are something that's essential. So despite the widespread use of the commercially available stereotactic frames, some centers lack the necessary funding for that. And also the complexity of the geometry of the workflow over these kind of subspecialties make it more like hard for the young neurosurgeon to catch up with the field. So how to make a difference in that regard? First, we had to address the limitations that was already available in the commercially available stereotactic frames. The first thing is the big number of pieces. The second thing is the complexity and the difficulty of assembly and also the mentally challenging geometry. These challenges made it difficult for all, most of the neurosurgeons starting the residency over there to start to catch up with the workflow and to understand the geometry. So the geometrical challenge lies behind the fact that the reference point that located outside the feasibly accessible or the physical reachable point with coordinate 0, 0 is actually outside the part of the brain that's imaged within the fiducial box. So I was obsessed over the past few months in the weekends to be able to draw 2D designs in notebooks, and after that I had to learn how to do 3D designing on CAD program so that I can convert that into reality to come up with this design. So basically, this is an open source on-shape software that allows you to build from scratch whatever 3D design you want. And after that, you can assemble even with a 3D printed skull, but here it's virtual. And this is what it would look like. So you can see here first it eliminates the need for the front post that is typically cosmetically unappealing for the patients, and also it focused mainly on the parietal eminence to reduce the risk of the epidural hematomas that can happen when you physically tighten the screw in the front post. So the main concept of that is less is more. So the main advantage of this design, it doesn't rely on the manufacturing accuracy or the additional device testing according to the phantom base. Instead, the point of reference is simultaneously visualized with the top posterior fiducial in the fiducial box as well as with the target by imaging. And this can be easily adjusted and can be easily imagined and visualized with young neurosurgeons. The second advantage is the least number of pieces. So it typically consists of only 5 components. First part is the Z-localizer helmet. Second part is the Y bar, and the third part is the X cylinder. Fourth part is the quarter arc, and the last part is the instrument holder. The main advantage of the quarter arc mechanism, as you can see here, is it offers you bilateral trajectory simultaneously, cutting the time of surgery into half. So typically in the OR, all of you have seen in stereotactic surgery, in order to get to trajectories, you have to readjust all the alignments and all the coordinates to get to the other side. So basically, the main idea of this is the double arc system, which offers you 2 coordinates, and as you can see in the workflow, it would be 4 coordinates so that you can reach multiple targets in the same way. And this also decreases the risk of long general anesthesia, putting the patient under a little bit less risk. So, and it also keeps the comparable freedom of movements that already existed in the previous BRW, CRW, Excel frames. So it offers the free 3 linear degrees of movement along the X, Y, and Z direction, and it also allows declination and azimuth angles for freedom. So going through it, first part is basically consists of 2 parts: a built-in localizer attached to a vertical Z-bar that has a posterior extension with a threaded hole for the anchor screw to be attached to the parietal eminence. Like I mentioned before, happens to be the most thickened calvarial part in the skull. So the second part is the Y bar, which is basically an anteroposterior Y bar with an inner sliding joint to be able to fit on the Z bar, and an outer window overlying that to reveal the engraved millimeter rule underneath. third part is a horizontal blind X cylinder that has an inner sliding joint to be able to fit on the Y bar with engraved angle markings on the outer cut section of the cylinder so that you can determine your declination angle. Fourth part is the quarter arc, which is, like I mentioned before, gives you the freedom of being able to do bilateral trajectories, and also it's attached to a hollow cylinder that overlay the X cylinder to be able to make the joint that moves horizontally within the X cylinder. Additionally, this can be fixed with a threaded hole from the anterior side and can rotate freely for 360 degrees. Last part is the instrument holder, a sliding piece over the quarter arc with a tubular cavity for the instrument to passes on, and the depth of the instrument can also be adjusted from a side screw so that the azimuth angles can be shown and can be fixed. So by now you must be wondering what the workflow would look like. So basically we apply the Z-localizer helmet over the patient's head, where making sure that the two side screws are diagonally adjusted and facing the varietal elements. After tightening those screws, you get to attach another vertical screw from above so that you can ensure that the frame doesn't move back and forth. After that, you take the patients to the scan so that alignment must be made sure of, like the two perpendicular tubes must be aligned on the imaging scalp, and the posterior localizer tubes must be perpendicular so that the axial cutting plane that you can see in the scalp, like the top line that you can see in the imaging scalp, should be perpendicular to the posterior localizer tubes, so that the distance between the anterior and the posterior fiducial is equal to the distance between the top posterior fiducial and the reference point of the frame and the posterior fiducial on axial imaging cuts. To even confirm that, we can make sure that the bottom localizer tubes are parallel to the axial cutting plane, which, like I said, the upper side of the scalp box, and this can also be double checked with a straight-sided eye shield with radio-opaque bars attached to both its sides and the front. So we also try to make a whole system so that we can dispense the whole fancy sophisticated software. So in order to do that, basically the main thing that is provided to you with the surgical planning software is the azimuth and the declination angle. So to get rid of that, we can manually calculate coordinates for entry and target. So now we have two coordinates for each trajectory. And we annotate that on the MRI slices to determine the safest trajectory, making sure you are avoiding any ventricle, any blood vessel, any sulci, and adjust the frame angles according to that. And this method can ensure that the workflow is not interrupted in case surgical planning software have technical or electricity issues. So you don't have to dispose all of your fancy stuff, but this can be like a second step in case anything happens. And this would what the workflow would look like. So this is the entry point coordinates calculation, so that we can calculate from the top posterior fiducial with 0.000, so that from that you can adjust the X, Y, and Z from that point to the entry. And then the target coordinates can be calculated as well. We can also double check the whole trajectory safety with an open source 3D slicer that is basically over there at no cost by drawing a point of the target and a line representing planned trajectory using the interaction option to navigate the whole planned path. And accordingly, a 3D model can also be created and visualized. And this is an example of drawing the trajectory by a line and navigating its path by interaction option. So in conclusion, some international institutes continue to flourish with the most advanced technology, enabling them to provide the optimum care for neurosurgical patients, but others suffer from the lack of equipment, high cost, and also, especially in a field where, as neurosurgery, where precision and accuracy are something essential. So we have to come up with new ideas so that we can cope up with those patients. And special thanks to all my mentors for pushing me and encouraging me to push my boundaries to navigate all there is in the field. Thank you. Oh yeah, yes, sir. So, and also we 3D print a prototype. This is not something you will see in the OR. So basically this would be the workflow. This is the Z localizer helmet. Attached to it by a back screw is the Y bar, and so it's basically this can move back and forth. Superior and inferior, and from that point you can attach the Y bar. After that, the quarter arc, and lastly the instrument holder. So this is what would be the eventual prototype look like. So yeah, any questions?
Not so much a question, but a comment. So this is, never-ending quest to try to build a better mousetrap.